Glenn is going to talk for about 15 minutes, and then Dr. Murphy-Zane for about 8 minutes, and then we are going to open it up for Q&A. So thank you for joining us, and Dr. Pfeffer, take it away, please.
Good. I guess it's morning for you guys, but for me it's afternoon. Thank you for coming, and thank you for letting me to link in with Zoom. Unfortunately, this trip that I have to the East Coast was planned a year and a half ago, so I couldn't be in Denver. And I want to thank the CMTA for everything they do for CMT patients and to help the community and for involving me on their medical advisory board. So I'm going to talk about high-arched, crooked, unstable CMT feet like this fellow here in the video. As some of you may know, every Sunday I spend a variable amount of time online doing chats or Zoom calls with people in the United States, patients around the world, and we talk about their feet. Some I can help, some I can't, but for everyone I've not spoken to, I dedicate this talk to you. So let's see how we do. Okay. So for those of you who don't know me, some do, but I'm Glenn Pfeffer. I live in Los Angeles. I work in the Department of Orthopedic Surgery at Cedars-Sinai Medical Center. Good. I've done a lot of CMT surgery since 1989. It's more than 1,400 now. That's probably the most that anyone's done in the world, although it's hard to know for sure. I've had 3 foot surgeries myself. My foot always hurts. And I just mention it because I know that it's helped me understand a bit what patients with CMT go through. I didn't know what I had for 50 years. And then when I figured it out, it was sort of a shock. And I know a lot of CMT patients don't know what they have until later in life, and then it's sort of a shock. I have no financial disclosures. I'm an employee of Cedars. That's really it. Now, this is a time of great hope, truly great hope for CMT. There's breakthroughs every day in research. Braces are improving, the materials they use and how they're fit. And certainly there are incredible advances that have taken place in surgery. The problem is that the advances in surgery haven't been promulgated sufficiently. They're not well understood by many people. This young man, for example, who lived in chronic pain and instability, was told that one of the major medical centers in the world, what you need to do for your feet is wear braces. And that's in 2024, absolutely ridiculous. So let's start in the beginning so we're all on the same page. What causes CMT problems? Well, the foot's complicated. There are 29 muscles. Of these muscles, 19 are in the foot, 10 come from outside of the foot. And like this tug of war, they're constantly pulling back and forth against each other to keep a foot balanced. With CMT, that goes wrong, however, as you know. Some muscles stay strong and other muscles get very weak. And that causes a twisting deformity. Not everyone has a high arched, or what we call cable-varus foot, but about 75% of patients do. And they vary tremendously, though. Some are worse than others. This is a moderately bad problem, but you can see the right side's worse than the left. It's not always symmetric. Why this occurs is because the muscles on the inside of the leg usually stay strong the longest, and the ones on the inside get weak early on. That causes the heel to twist around, the foot to become contracted, and this deformity develops. Now, what happens is, and for those of you who are listening, many of you know this, you start walking on the side of the foot. Now, it's a motor sensory neuropathy, so some people don't feel that well, which I guess is a blessing in this case because they don't feel what would normally be a lot of pain. But unfortunately, what happens to those people is over time, they can wear an ulcer, wear down the skin and get an ulcer. Now, there's no question that people with CMT have some neuropathic pain. Some have more than others in their feet, worse at night. But there's also no question that this hurts. If you question whether this hurts or not, just ask a friend of yours who has no CMT, to twist their foot inward and walk around for about a mile on concrete and see how they feel. They won't go more than 3 or 4 steps. So the pain that people experience in their feet with these crooked feet that have CMT absolutely improves after surgery once you stop walking on the side of your foot. Now, there's also a problem with the muscles in front. Not everybody gets a drop foot, but many do. And you can see what's happened to this young person. They can't lift their foot up at all. But luckily, they have muscles that are pulling their feet in. And I was able to operate on this person and get them out of braces and give them a flat foot. Now, feet, CMT feet, they come at all different ages, all sorts of different shapes. They're as different as the people who own them. But these types of feet, these crooked feet that even when you twist them around are not flat in a brace, have one thing in common. Every single one of them could be helped with an operation in 2024. Each of these people were told there was nothing to do. The woman on the left saw multiple practitioners in Australia. She was 7 or 8 year old. In the middle was told that your foot has to be in a brace at a major institution in Boston. It's countless, really, about the misinformation that exists regarding surgery. And that's because if you poll most of the physicians in the country, or at least half of them, who see CMT feet, they'll say the only treatment for it is a brace. Not in the kind of feet that we're talking about. Now, let me make it, please, very clear to everybody. A brace is life-changing for many people. This woman is paralyzed below the knee. She can't walk without holding on to the wall. Braces are life-changing for her. She scampers down the hallway, back and forth. She happens to have one brand on, but there are many brands that work. They're ground reaction braces. They bend as you move forward, and as you step off, as you start to toe off, they spring you back. And they're just remarkable. But they're not for somebody with a crooked foot that doesn't fit flat in the brace. This person had surgery, 16 years old, had 2 surgeries done elsewhere, and this is what they're left with. And this is not the goal of an operation. What you need after surgery is a plantigrade, which means flat foot on the ground, a stable ankle that's not rolling over, and ideally no foot drop. It's pretty much always possible to create a plantigrade foot and a stable ankle. It's not always possible to get someone completely out of a brace because of the foot drop, but in most cases, I can. All you need is one good muscle to get someone out of a brace completely. But the surgery, as I said, is complicated. Well, that young boy was operated in a very good medical center by a well-thought-of pediatric orthopedic surgeon. But it's hard to have the experience with this. I've been very lucky. This didn't happen overnight. And most people in the country, I don't really know what they do. If they're interested in CMT, maybe they'll operate on 4 people a year or 6 people a year. But it's hard. It's a hard operation to learn how to do. And here's why. This is the surgery board from a surgery we did a few years ago. I just happen to have a picture from Cedars-Sinai. There are 18 surgeries that were done, 18 different procedures that had to be done. It takes 4 or 5 hours. And each of them is like a gear in a complicated watch. They each play off the other. And if one fails or is not doing well, it affects all of the others. And that's the hard part to teach. I try to teach our fellows, of course. Now, what do you do in surgery? What we do is we start by untwisting the deformity of the middle of the foot. Everything's contracted to one degree or another, and we untwist it. This is actually a video in reverse of a towel being wrung out. So we let go of the soft tissues, and slowly the foot starts to untwist. Then, just to make the point, here's a twisted, uneven shape, a pepper. Now we take bone wedges, or in this case, pepper wedges out, and this will bring up the foot. Again, it's hard to teach exactly how much bone to take out. One day, not too far in the future, especially if we can get my last research project going, we'll have an AI program that'll tell surgeons that don't have as much experience how much bone to take out. I'm very excited about that. After that, we move tendons around, we transfer them, we try to balance the pull so the foot doesn't twist one way or another. Now, these people, I'll just give you a couple of examples. I've had surgery. On the left image, both feet were the same. We usually operate on the worst foot first. So on the left side, left image, the left foot's been operated on. You can see the right. On the right image, the right foot's been operated on. You can see the left. I think it speaks for itself. Here's 2 weeks after surgery.
Oh, wow. Oh, my goodness. It's so great.
Now we're going to let go of it just for a second. Now hold your leg. Okay, here we go. Go ahead, Alan.
Oh, my goodness.
You can see her left foot there. We had no motion in it. And
Come back home.
Oh,
a month after Sarah had her right foot done, she got married. We just did her left foot. Now, what's wonderful about this surgery is you have a back operation. Maybe it takes a month or 2 months or 6 months or a year to get better. 2 weeks in the office, people are nervous. The sutures have to come out. They can see their foot and they know they made the right choice. I know I made the right choice. Now, on the left, just one last example, is the fellow I showed you. He was told there's nothing to do but to wear a brace. Here he is 18 months after his surgery. He's going to the gym. He doesn't need a brace. He walks flat-footed. I mean, there's no issue here about the benefit of having a flat, stable foot that can go up and down without a brace. But he was told to wear a brace for the rest of his life before the surgery. Now, I started Instagram 8 years ago. I wasn't sure about it, but everybody kind of supported it and thought it was a good idea. Go to it, take a look at it. We now have almost 18,000 followers. You can direct message anyone on there to find about the surgery and how it went. And some of the views have 6 million views. It's absolutely incredible to me. But I would encourage you to do that, to go into more depth. Now, the question I have is, I started in practice in 1984, and that's the computer that had just come out, the first Mac. Is anyone in the audience still using that Mac? Come on, if you are, you should probably sell it for a lot of money as an antique. But no one is using that Mac. And you're using something like this. And the same thing has happened with surgery. Why are some doctors stuck in the idea that surgery hasn't advanced since 1984? It has. And largely because of research that's been done on CMT surgery. Honestly, the majority of which we've done at Cedars-Sinai. This is an excellent review. If some of you want to get it to your doctors or to read yourself, it's available. We've done research that shows that this can be done as an outpatient. Some hospitals refuse to do it that way. You can use a pain pump and push the pain button, so you'll diminish any pain you have for 5 days, 4 or 5 days. We know how to correct the twisted deformity in the foot. This has all been done with very sophisticated three-dimensional analysis. We published a paper on the best way to do tendon transfers, or at least the best options. There's not just one way to get somebody out of a brace. There are several different ways. Some of the more important research we did was on the abnormal shape of CMT bones. And other people in the world have confirmed this. But if you have abnormal pull on the bones as you develop as a kid, the bones get misshapen. So you're not only, as a surgeon, trying to correct the twisted foot, you're actually trying to correct the twisted foot that has an abnormally shaped bone that no one understands. But again, one day AI will make all the difference. I'm not sure when that will happen, but it will. What was very gratifying is a paper we came out with this year that shows that the approach that we take actually returns the bones, the abnormally shaped bones, and the joints to a near normal. I didn't believe this at first, but we looked at the data multiple different ways. And so we're restoring these CMT cable varus high arch feet to near normal positions in turn, And the most important article we have is just coming out this month. After a lot of revisions, we looked at 95 feet. Before surgery, patients had worse physical function and more pain than the general population. No surprise. And after surgery, the patients were statistically improved with better physical function and pain. It was a very significant result. Now, it's important to remember that these are big surgeries and complications certainly can occur. I had, but keep in mind, it's out of 1,400, maybe 1,500 surgeries now. We've had one bad infection. The biggest problem we had is actually overcorrection. For maybe 8 or 10 people, we made the foot too flat, and some of them had to come back. It's as these techniques evolved, they turned out to be so powerful that the foot got overcorrected, but that's not happening, thank God, much anymore. And one of the most severe infect problems I've had just actually happened, and I want to warn the CMT community and all of you about CMT2C. This has never been reported before, but the TRPV4 mutation probably affects what's called fibroblast migration and collagen production, which is what help wounds heal or make wounds heal. And this young girl from Hungary had breakdown of every single one of her wounds. She's actually still in the hospital. Very rare, unheard of. No one knows about this, but we'll publish this. But until it gets published, if you want to have or you need to have a big 5 or 6 hour operation and you have CMT2C, be cautious. And that's it. I would leave with these final words. Please tell your friends, tell everyone you know. Reach out on social media. Tell the brace makers, the orthotists, but especially tell your doctors and your neurologists that in 2024, no one has to live with a crooked, unbalanced, painful foot. Thank you.
Thank you, Dr. Pfeffer. Appreciate it. We're going to turn it over to Dr. Murphy-Zane, please, and then we will save Q&A in just a few minutes. Thank you.
That's a great talk from Dr. Pfeffer, and I appreciate all the work that he's done over the years helping advance our knowledge of the surgical interventions that we do with CMT. Thankfully, I'm not covering too much of the foot surgeries that we do for this because I don't think I can really beat some of the illustrations in his talk. Just real briefly, I'll start talking to you guys. I'm a pediatric orthopedic surgeon. We're at Children's Hospital, Colorado. Some of our physical therapists, and earlier in the panel, we were talking about our multidisciplinary clinic. My other interests pediatrically are clubfoot, which is some ways similar to CMT feet. I'm also interested research-wise in hip dysplasia, so I've really appreciated our CHCO multidisciplinary clinic in that we're kind of looking more holistically at the child. I do agree with Dr. Pfeffer that surgical intervention is very, very useful, and I don't think we need to delay it until the kiddos are 18 years old or full grown. Yeah, why don't we do some questions from Dr. Pfeffer? Okay.
Yes, we have a question for you, Dr. Pfeffer. Hang on one second.
I would just have Dr. Murphy say she made an excellent point about when to operate on patients. And these questions I put together, but I've neglected to put that on there, are really the most common ones that people ask. And really, what she brought up is critical. When do you operate? And, she and I can discuss that. But from my point of view, you operate on somebody as soon as they can't be comfortably braced. I mean, after they've gone through conservative care. There's a lot that's done for 5, 6, 7-year-olds to avoid surgery. But if they can't be put comfortably into a brace, I think the earlier, the better. Big problems start small. And
Thank you, Dr. Pfeffer. Can you hear me, Dr. Pfeffer? It's Laurel.
Yes, ma'am.
Okay, hang on one second. We have a question. Hi, Dr. Pfeffer. Thank you very much for your Instagram. It's been a huge source of support for me, given my son's diagnosis last year with 1A. I know you do a lot of corrective surgeries, and I wondered if there is a common mistake or mistakes that you see from prior surgeries or whether it runs the gamut of things that have been done incorrectly.
Yeah, that's yes. There it is. Well, there are two things. One is not having done enough, period. You saw the gears, you saw the 17 procedures, you saw, I'm a moderately fast surgeon. I was trained as a hand surgeon, but it takes 5 hours for me to get through all these incisions. People don't do enough. And two, and we can see what our pediatric colleague says, but a 12-year-old girl should not be treated surgically like a girl. Her foot is the foot of an adult. And a 13, 14-year-old boy is not a boy anymore. And the problems that I see usually are kids that have been operated on as adolescents and have been treated with insufficient surgery because they're being treated as a 9-year-old. But for a 9-year-old, you don't do all that much. You balance things out and do some soft tissue releases. So that's the key. I've been asked to give a talk coming up in Canada about the difference between pediatric surgery and adult surgery, and that's the main message. Don't treat adolescent kids like kids. Treat them like adults. And the surgery is just different, or it's more aggressive for adults. Does that make sense?
Yes. Thank you, Dr. Pfeffer. We now have Dr. Murphy-Zane's slides up, so we're going to turn it over to her, and then we'll get back to Q&A. Thanks, everyone.
So again, welcome to Colorado. I hope that you guys had a good trip out here. I started off on the East Coast. I've been out here about 12 years. And again, we started our CHCO multidisciplinary clinic about 5 years ago. This is Children's Hospital, Colorado. We are honored to be a Center of Excellence from the CMTA, and we do work in close ways with our University of Colorado colleagues, and my colleague, who I think has done some work with Dr. Pfeffer, Ken Hunt, is the adult CMT surgeon that we generally work with over there. This is our team. We have really feel strongly about a multidisciplinary approach with the kids, and it includes rehab, ortho, neuro, PTs, geneticists, and clinical coordinators, and our research assistant. I also have many partners working with me in the Department of Orthopedics who subspecialize in more complex foot surgery, spine surgery, adolescent hip surgery. And Cheyenne Day and Jason Rhodes also run our gait lab, which is one of the best gait labs, I have to say, in this region. And we sometimes will use the gait lab, which I won't go into detail at this point, preoperatively and assess again postoperatively to see how we're doing with our surgeries. Big picture numbers, 265 CMT patients have been seen at Children's Hospital over the past decade. Some of them have graduated onto the adult side. And 101 of them have been seen comprehensively in our pediatric CMT clinic. Our clinical breakdown, again, we, like most centers, are primarily CMT 1A. We do have a large CMT 2A population and a variety of the different smaller subtypes. This correlates well with reported incidents from Toronto Hospital of Sick Kids, where they have a similar distribution of subtypes. Now, we all know that CMT is a family affair. We see a lot of siblings come in together. We see one sibling diagnosed with CMT, then their brother gets diagnosed, and then it goes on Facebook page for the family, and the entire family comes up with CMT diagnoses because someone says, oh, well, Grandpa Joe's feet used to look like that too. We have a very stepwise way that we look at this. We're very invested in trying to assess how this is affecting to the children's lives. So first thing we do on patient IQ before the patients come, hopefully, is they fill out PROMs, patient recorded outcome measures, and we use the PCMT QOL to try to track how they're doing. And eventually, hoping to use this more effectively to assess our interventions. Does physical therapy make a difference? Does surgery make a difference? Does bracing make a difference? We use the CMT PEDS score. This is a validated, reliable global measure of the disability of children with CMT. It has 11 subtypes that look at strength, dexterity, sensation, gait, balance, power, and endurance. The children from all of these subtypes are assigned a score from 0 to 44, with a higher number being a higher burden of the disease. We currently try to do these assessments yearly. And sometimes we'll do subtype scoring depending on what we're doing with the kiddos. So here's Caitlin and Carolyn and Megan doing some of the activities that we do with the children. The subtests within the CMT peds include dexterity, strength, sensation, and balance, motor function, both upper extremity and lower extremity. They do a lot of peg tests and grip tests. Then we get them out in the hallway and have them do jumping and balance beam things and a 6-minute walk test, which is a test of endurance. We do a bracing assessment. I always like to see braces kind of destroyed because it makes me know that the kids are out there and using them. You can destroy them as much as you want, just use them. And part of the CMT PED score is this foot posture index. This is useful because we can put a number on how much cavus they have, how much varus they have, how much flat foot they have. And this is on a score from negative 12 being the most supinated and positive 12 being the most pronated. Our decision for foot surgery, as Dr. Pfeffer just very well outlined, is a worsening foot posture index based on the CMT PED score, not tolerating their braces. Stress fractures. I don't know if you guys can appreciate that. This is a pointer. This at the base of the fifth metatarsal, so on the pinky toe side of this kid's foot, at the middle part of the foot, you can see that they have a fracture. And this happens because they are walking on the lateral border of this foot. And so sometimes they don't even realize it. We've had new patients come in and say, yeah, my feet kind of hurt. And we're like, okay, well, let's get some x-rays. And they've been walking around with a stress fracture for we don't know how long. Also worsening PROMs, meaning is this functionally really bothering you? We try to start, I think we're working with a working hypothesis that actually earlier intervention is better for these kiddos because we don't have to do the bony work. A younger child might just need a heel cord lengthening, might just need a transfer, but might not need to have their heel cut and slid over. So we're not going to go all into the technical details of the surgery, but we're beginning to really believe that earlier intervention is probably a good idea. Perioperative care, we feel strongly about preoperative PT for mobility training. Postoperative PT arranged for preoperatively so the kids have the equipment that they need at home before they actually go home, because we don't like to have a kid come back 3 months after their foot surgery still in a wheelchair because they have no way of getting around. We also urge the surgeons to do the practice of doing some intraoperative or postoperative casting so that they have a postoperative AFO. The goal is, yes, eventually to get them out of an AFO, but a lot of times they have so much weakness coming out of the prolonged period of casting that they still do need an AFO. And it's a shame that you've done all of this surgery and they come back and they've gotten tight or scarred down in a way that's not desirable. My point I'm going to make here is I'm going to transition and say CMT is more than high arches. I think everyone in this room understands that. So foot deformity, yes, we agree. In our clinic, 68% of kiddos have pes cavus, or these high arched foot. But that means a third of them either have flat feet or don't have high arches, but they are toe walking, but they are falling frequently. And they have upper extremity weakness that we also do need to look into. Here's an example of kids that we saw just this week, a pair of brothers. And their parents knew there was a family history of CMT1A. They had, the father had multiple surgeries with Ken Hunt and had a hip replacement. They had seen us earlier when the boys, maybe 6 or 7 years ago when the boys were younger, but because the boys were doing pretty well, they had not come in for follow-up. They came in because the boys were having problems with their stance in their golf swing, really specifically. And they wanted to know what we could do about it. So this is the older brother. He had a base of fifth metatarsal fracture for which he had been seen by the orthopedics department in 2022. So we had a long conversation. It's probably time for this kiddo to have something done about his foot. But wait, there's one more thing that I, as the orthopedist in our CMT multidisciplinary clinic, do routinely, which is we get a scoliosis x-ray. I get a scoliosis x-ray because I get a hip film for free. Well, what else is going on with this kid? He has scoliosis and he has a subluxed right hip. The hip's not bad. So we might just watch that hip. The scoliosis, we're not going to do anything right now. It's not a bad scoliosis, but at least we know that we need to do something about that. So we had that conversation. Then we looked, this is what we do for scoliosis. There are some subtypes, which we've reported on at MDA, that have rapidly progressive scoliosis that's not amenable to bracing. I have some CMT 1A patients who seem to be doing okay with nighttime bracing for their scoliosis, but we're going to keep an eye on them because we want to make sure that they are not a rapidly progressive subtype. This is thoracic screw, pedicle screw fixation for scoliosis, and so this is what some of our kiddos need. This is the presentation of the type 4C CMT patients, some of which went on to have scoliosis surgery. This is the other golfer, the 11-year-old brother. He has a straight spine, thank goodness, but he has a subluxed left hip. And of all the things we talked about with them on Thursday, hours-long conversation, this is actually the thing that needs to get addressed first. The feet are bad, his feet are not pretty, but actually a dislocated hip is worse. So if we pick this up, so this goes on to what do I do with the rest of my week at Children's Hospital Colorado. I see a lot of baby hips. I do a lot of assessments of infants with hip dysplasia. They get up to 6 months old. You can do an ultrasound to check it. There's a series of things that you can do up to about 12 to 15 months old. You can brace those kids and fix their hips. CMT, EDC, CP, neuromuscular reasons, they might not all present as infants, but we don't know because we actually haven't looked at CMT babies. So when they're 2 and they have dislocated hips, we do proximal femoral varus osteotomies. They get these 90-degree plates. This baby, I don't know if you guys can appreciate, has also had acetabular osteotomies in their pelvis. There are 2 wedges of bone stuck into her pelvis to reshape that acetabulum. And this is this 3-year-old now after her plates have been removed. This golfer is probably going to have this surgery, which is called a periacetabular osteotomy, which is basically where we cut the acetabulum free from the pelvis, rotate it where we want it to go, and fixate it with these screws. So when we looked at our patient population at Children's Hospital, more than a third of our patients either have scoliosis or hip dysplasia or both. Of the orthopedic surgeries we do, sure, more than a quarter of them we do their feet, but 3% of them have spine surgery, almost 10% of them have hip surgery. Some of them are referred to us from the spine or hip service, and some of them have hand. I'm going to briefly talk about hand surgery. I got it. She's got me on time. She told me multiple times I was going to have to be on time. So this is a little girl that we have who's CMT 2A, rapidly progressive. She's already had Achilles tendon lengthening in her right posterior medial release, which has actually done great for her walking. She does dance, cheer, and she likes to kayak with her family, and she had decreased grip strength. So she had an opponent's plasty. She had some hand tendon transfers to improve her grip. I don't know if she would have had that if we had not been doing a multidisciplinary approach to assessing how this child was doing, because we look at their grip strength. So CMT is more than high arches. It's a lot of high arches, but I think our comprehensive approach is teaching us that we really need to look at that child more comprehensively in an orthopedic way.
That was impressive. Okay, we are, even though we're a little bit over, we are going to take a couple minutes for questions. And we're going to start with the Zoom because do they have a question? Any question? Go ahead, Cater. Do you need the mic? Okay. Come.
Thank you. This question's for Dr. Pfeffer. Can you correct triple bone anthrodesis, and are those procedures done anymore?
Can you hear me?
Yes.
Okay. Triple arthrodesis, it's when you fuse the three major joints in the back of the foot. Sometimes it's needed. Usually it's done for salvage. But the younger the patient, the more you'd like to avoid it. There's nothing wrong with a triple arthrodesis if it's done well, but so try to avoid it if you can. We do that rarely, except as a salvage procedure.
Hi. My question is, when we're looking ahead at potential treatments that would either stop demyelination or even allow the nerves to remyelinate, if you've had surgeries like tendon transfers and different things, how will that affect your foot?
Respectfully, I always say, Michelle, no, my neurology patient. I think that's a terrific question, and I think that we don't know. I think that a lot of the stuff is going to apply to the children. I think some of the medicines that are coming out are going to be more applied to medicines, just like SMA. I mean, a lot of times the medicines that have been most useful for the kids with spinal muscle atrophy are most useful the younger a child is. And so I don't think it's going to change much in an adult, what's going on with them. And we'll just have to see with the kiddos. I'm going to say one thing because someone asked me this earlier during the panel and I kind of teased and said I was going to talk about this now. I think that from our findings with scoliosis and hip dysplasia, the question is going to be, if you have a known diagnosis of CMT1A, how soon do I need to get my kids checked? And I would actually say as soon as possible. I would say we should actually establish that diagnosis, because if I could see a kiddo earlier, there are other things that we can do for their spine. There are other things we can do for their hips, and those things don't show up looking at them. You actually have to do some sort of imaging study to see if they have those problems.
Thank you.
Yeah.
Dr. Pfeffer, go ahead.
I think there are a lot of things to worry about in life, and there's certainly a lot of things to worry about CMT and surgery. But for me, to worry about that a nerve that is basically dead being resurrected by a medication is very low on the list. I think that the medications and the gene therapy will alter the course of the disease and may increase muscle strength some percentage, but it's very unlikely that it's going to reverse where it makes a difference, a muscle or a nerve. But because remember, even if the nerve starts to wake up because of the therapy, the muscle will never work because muscles become fibrotic and hard. So what's done is done in terms of answering your question. And the most important message I would leave anyone is that people ask me, what's the point? I've got a progressive disease. Why should I do this operation? Well, if you start at a C in terms of your foot position and you get worse because it's a progressive disease, you end up an F, all right? But if with surgery, if you're a candidate, you can move up to a B plus or A minus, and then God forbid you get worse, well, then you can end up at a B. But so it's completely worth doing the surgery. And in answer to your question, even if the nerves start to resurrect because of the treatment, the muscle won't. Fibrotic muscle that hasn't been innervated for 4 months or 5 months will never function again. It's gone.
Thank you, Dr. Pfeffer. We are going to wrap this session. I know that we could have an entire conference on foot and ankle surgery for CMT. There's so much information out there. I would strongly encourage everyone in the audience, if you're not following Dr. Pfeffer on Instagram, he shares incredible information. Also on the CMTA's website, we have recorded webinars where Dr. Pfeffer is clearly discussing bracing versus surgery. I have personally found that webinar to be so helpful. Reach out to me if you're having trouble finding that information, and I will be sure to get it to you. Dr. Murphy-Zane will be here a little bit longer to answer any questions. Thank you so much. I apologize for the technical issues, but we are here, we did it, and it was phenomenal. Thank you all. Dr. Pfeffer, thank you for sharing your vacation with us.